All right, nursing students out there getting ready for exams or maybe even clinicals. Let's talk about something you're going to see a lot of.
The respiratory system.
Yeah, you sent over some pretty intense material, so we're going to
We are.
deep dive into it today and pull out the stuff that's going to really make a difference when you're actually at the bedside.
When you're actually taking care of patients.
Exactly.
Yeah.
So we're going beyond just like, the textbook stuff.
Yeah.
We're going for like real clinical application.
Yeah, you got it.
So let's start with just like a super quick overview.
Yeah.
Your document kind of breaks the respiratory system down into the upper and lower tracts,
Right.
but it's all connected.
Right. It is all connected.
What happens up top with like, your nose
Absolutely.
affects what's going on all the way down in those little alveoli.
Those millions of alveoli where the magic happens.
Speaking of alveoli, I was blown away by this fact. The total surface area of all those tiny little air sacs is like the size of a tennis court.
It's incredible, isn't it?
A lot of real estate for gas exchange.
Right. It's a huge amount of surface area, and that's really crucial for efficient diffusion, for that movement of oxygen from the alveoli into the blood and CO2 going back the other way.
Yeah, that makes total sense.
Yeah.
So let's start at the beginning of our airflow journey.
Okay.
Up top in the upper respiratory tract.
The upper respiratory tract.
So we've got the nose, the pharynx, the larynx, and the trachea.
Right.
Sounds pretty straightforward.
Yeah.
But I bet there's some stuff that we might miss if we just skim over this section.
There are a lot of clinically relevant details that we need to pay attention to.
Yeah, so the nose.
The nose.
I mean, it filters the air.
Absolutely.
But what does that actually mean for nursing care?
That's a great question.
Yeah.
Because, we all know the nose filters air.
Yeah.
But think about it from the perspective of a patient who has a compromised immune system. So someone who is, immunocompromised, even a simple cold can be a much bigger deal for them, right?
Totally, yeah.
So understanding how the nose filters air, how it humidifies air, that can really guide your practice when you're thinking about things like proper hygiene and infection control measures for those patients.
That's a good point. Okay, so air moves from the nose back to the pharynx.
Right.
Which is a shared pathway for air and food, which always makes me a little nervous.
I know. It's like a busy intersection with traffic coming from both directions.
Yeah, and you're just waiting for an accident.
Exactly. And that's where the epiglottis comes in, right? That little flap of tissue.
Right.
Acting like a traffic cop, directing food down the esophagus and air into the trachea.
But things do go wrong sometimes.
Oh, they do.
Which is why we have to, understand that anatomy.
Absolutely.
To know, how to manage things like choking or placing breathing tubes.
Exactly. Think about intubation in the ICU.
Yeah.
Knowing exactly where those structures are is critical for doing that procedure safely.
Totally. Okay, and then we have the larynx.
The larynx.
Okay, the voice box.
Okay, the voice box, yes.
Which is pretty important to us right now as we're talking on a podcast.
Absolutely critical for communication.
Good.
But for nursing students, I think it's important to go beyond just thinking about voice production.
Okay.
The larynx is also crucial for protecting the airway.
Oh.
Think about it. When something irritates our larynx, what do?
We cough.
We cough, exactly.
To get it out.
Right. So that cough reflex is a protective mechanism.
Okay.
And assessing a patient's cough can give you valuable clues about their respiratory health.
Oh, that's interesting. So like a weak cough?
A weak cough could be a sign of muscle weakness or a neurological problem.
It's all connected.
It is all connected.
Okay. And then finally we have the trachea.
The trachea.
Eki, the windpipe.
Yes, the windpipe.
With those C-shaped cartilage rings.
Those C-shaped rings, that's a classic anatomy question. Why that shape?
I remember vaguely from anatomy class that it's so the esophagus can
expand behind it.
Expand behind it when we swallow.
When you swallow, exactly.
I feel like it's one of those things I memorized for the test and then immediately forgot.
Well, now's the time to bring it back from the depths of your memory banks.
Okay.
Because think about it. What happens when those rings are damaged, say, from trauma or a tumor?
Oh.
That can compromise the airway, right? Leading to breathing difficulties, or during intubation, if the tube is applying pressure to the back of the trachea, it would actually impact the esophagus and cause problems with swallowing.
Wow. I'm starting to see how all these little anatomical details can have big consequences.
Absolutely.
Okay, so we made it through the upper respiratory tract.
We did! good.
Let's head down to the lower respiratory tract,
To the lower respiratory tract where things get even more interesting.
where things get even more interesting.
Yeah, this is where we really see the beauty of the body's design, with the trachea branching into the bronchi,
Right.
then into the smaller bronchioles, ultimately leading to those millions of tiny alveoli that we talked about.
And the alveoli are where the magic happens.
The magic of gas exchange.
Gas exchange.
Yeah.
I remember learning that their walls are super thin, like only 1 cell thick. Why is that so important clinically speaking?
Well, that thin barrier is what allows for efficient diffusion,
Okay.
but it also makes the alveoli incredibly delicate and vulnerable to damage.
Oh.
So think about conditions like acute respiratory distress syndrome or ARDS, where fluid leaks into the alveoli.
Oh, yeah?
So that fluid buildup thickens the barrier, making it much harder for oxygen to get into the bloodstream.
So even if we crank up the oxygen on a ventilator,
Right.
it might not be enough because it can't cross over
Exactly.
into the blood. It's all about that barrier.
It is all about that barrier.
Okay, and before we move on, can't forget about the pleura,
The pleura, yes.
that double-layered membrane that surrounds the lungs.
It's like a protective sac.
It helps reduce friction.
It does.
But it also, I remember something about maintaining lung expansion and negative pressure.
You're bringing me back to physiology class.
I know, vaguely. Can you remind me how that works?
So think of the pleural space as like a sealed container, right? And the pressure inside that space is slightly lower than the pressure inside the lungs,
Right.
which helps keep the lungs inflated. But if that negative pressure is lost, say, from a punctured lung, like a pneumothorax,
Oh,
the lung can collapse.
that makes so much more sense now.
Good.
Okay, so we've covered the basic anatomy
The basic anatomy?
of the upper and lower respiratory tract.
Yes.
Where do we go from here?
Well, let's dive into the dynamic duo of respiration.
Okay.
Diffusion and perfusion.
Ooh, already.
These are two concepts that are absolutely vital for understanding how the respiratory system functions and how we can best care for our patients.
Perfect. I'm ready to deep dive into that. But first, I need a coffee refill.
Okay.
We'll be right back to explore the fascinating world of gases moving around the body.
Okay, so coffee break's over.
Back to the respiratory system.
Back to the respiratory system.
I'm ready.
Time to put those caffeine-fueled brains to work. All right, so we left off talking about diffusion and perfusion.
Right.
Two processes that are absolutely vital for getting oxygen where it needs to go and removing that waste product, CO2.
And those concepts are more than just textbook definitions, right?
Absolutely.
As future nurses, we need to understand how they actually play out in real-life patient care.
Absolutely. So let's break it down. Diffusion is all about concentration gradients.
Okay.
Think of it like this oxygen is hanging out in those alveoli, just waiting to party in the bloodstream.
Okay.
And since there's more oxygen in the alveoli than in the blood, it naturally wants to move to where there's less of it.
Kind of like how a crowded room clears out when someone opens a door to a fresh open space.
Perfect analogy.
Everyone wants to escape that stuffy air.
Exactly. So oxygen diffuses across that super thin alveolar membrane and jumps onto those hemoglobin buses in the red blood cells,
Okay.
ready to be transported throughout the body.
Right.
Meanwhile, CO2, which is more concentrated in the blood, moves in the opposite direction from the blood into the alveoli to be exhaled.
It's like a perfectly choreographed dance.
It is.
Everyone's moving in the right direction at the right time.
Exactly.
But what happens if something throws off that choreography?
Uh-oh.
What if there's a problem with perfusion?
That's where things can get really interesting and potentially dangerous for our patients.
Okay.
Imagine this scenario: you're assessing a patient and you notice that their oxygen saturation is low, even though their respiratory rate is normal, and they don't seem to be struggling to breathe.
Yeah.
That could indicate a problem with perfusion, meaning there's not enough blood flow to pick up the available oxygen in the alveoli.
So even if there's plenty of oxygen just hanging out in the lungs,
Right.
it can't get into the bloodstream if the buses aren't there to pick it up.
Exactly.
That makes me think about conditions like pulmonary embolism,
Yes.
where a blood clot is blocking an artery in the lung.
You nailed it. That's a classic example of what we call a ventilation-perfusion mismatch, or VQ mismatch for short. So in a pulmonary embolism, you have good ventilation air is getting to the alveoli, but poor perfusion because that clot is blocking blood flow.
So VQ mismatch is when that balance between ventilation and perfusion is off.
Exact.
We talked about a high VQ, like in a pulmonary embolism,
Oh, yeah.
where there's more ventilation than perfusion.
Yeah, more ventilation than
And
perfusion.
what about the opposite, a low VQ?
A low VQ, also known as a shunt, is when you have good perfusion but poor ventilation.
Okay.
Think about a patient with pneumonia.
Okay.
The alveoli are filled with fluid or pus, so even though blood is flowing past them, it can't pick up much oxygen because the air spaces are blocked.
It's like having a traffic jam on the oxygen highway.
I like that.
All those red blood cell buses stuck in traffic behind a blocked lane.
Exactly. And the clinical implications of these different types of VQ mismatch are huge for nurses.
Okay.
We need to understand this underlying physiology to make sense of our assessment findings,
Right.
to interpret lab values, and to anticipate potential complications.
So speaking of assessment findings, can we dive into that a little bit more?
Absolutely.
You mentioned noticing a low oxygen saturation.
Right.
What are some other key things we should be looking for when we're assessing a patient's respiratory status?
Great question. As nursing students, you're learning a ton of assessment skills, and respiratory assessment is one of the most crucial ones.
Yes, it is.
It's not just about listening to lung sounds,
Right.
although that's definitely important.
Right.
It's about taking in the whole picture, observing their breathing pattern, their effort, and using your senses to gather clues.
Okay, so let's say I'm walking into a patient's room for the first time.
Okay.
What are my first steps in assessing their respiratory status?
First, just take a moment to observe.
Okay.
Look at their chest. Is it rising and falling symmetrically?
Okay.
Are they using accessory muscles to breathe, like those muscles in their neck or shoulders?
Right.
That can indicate that they're working harder to breathe.
Okay.
Then, count their respiratory rate and note the depth of each breath. Is it shallow or deep, rapid or slow?
Right, so those are all things we can do without even touching the patient.
Exactly.
And then we move on to actually listening with our stethoscope.
Yes.
I'll be honest, I'm still a little intimidated by auscultating lung sounds.
I get it. It takes practice and a good ear to differentiate all those sounds.
Yeah.
But think of it like a puzzle.
Okay.
Each sound provides a clue about what's happening inside the lungs.
Okay.
Wheezing, for example, often indicates narrowed airways, like in asthma.
Right.
Crackles can suggest fluid in the lungs, which could be due to pneumonia or heart failure.
So it's not just about hearing the sound.
Right.
It's about connecting it to the underlying pathophysiology,
Exactly.
thinking about what it means.
Yes, and don't forget to ask the patient about their symptoms.
Right.
What are they experiencing?
All right, like what are they feeling?
Do they have a cough, shortness of breath, chest pain?
Yeah.
Their subjective experience is just as important as your objective findings.
Okay, that makes sense. So we've gathered all this information through observation and listening and talking to the patient.
Right.
Now, how do we use this knowledge to actually guide our care?
That's the million-dollar question, right?
This is where I feel like things start to click for me as a nursing student.
Good.
Taking that theoretical knowledge and applying it
Absolutely.
to real-life situations.
That's the whole point of this deep dive.
Yes.
To help you bridge that gap between textbook knowledge and clinical practice.
I love that. Okay, so let's say you're caring for a patient with a low oxygen saturation, rapid breathing, and you hear wheezes on auscultation.
Okay.
What are some things that might be going through your mind as a nurse?
All right, let me put on my thinking cap.
Yeah.
Well, based on what we've talked about so far, it sounds like this patient could be experiencing a problem with both ventilation and perfusion.
Okay.
The wheezing suggests narrowed airways, which could be due to bronchospasm or inflammation.
Right.
And the low oxygen saturation could indicate a problem with gas exchange, maybe due to a VQ mismatch.
Okay, so what kind of interventions might be appropriate for this patient?
Well, first I'd want to make sure they're getting supplemental oxygen.
Okay.
Then, depending on the suspected cause of the wheezing, we might consider bronchodilator medications to open up those airways.
Right.
And if we suspect a pulmonary embolism based on other assessment findings and risk factors, we'd need to notify the physician immediately and anticipate diagnostic tests and anticoagulant therapy.
Right.
You're starting to think like a nurse.
I am.
Connecting the dots between assessment findings, pathophysiology, and potential interventions.
Yes, and don't forget about ongoing monitoring.
Absolutely.
We need to constantly assess and reassess
We do.
our patients to make sure that our interventions are effective and to catch any signs of deterioration.
Exactly. You're on a roll.
It's like a light bulb just went off in my brain.
That's what we like to hear.
Okay, so I think we laid a really good foundation
A good foundation.
for understanding like the basics of respiratory assessment
Yes.
and the interplay between ventilation and perfusion.
Absolutely.
But we've only just scratched the surface.
There's a whole world of respiratory conditions out there.
Right.
That nurses need to be familiar with.
My notes mention things like pneumonia, asthma, COPD, and pulmonary embolism.
Yes. Those are all conditions that we're going to see a lot of as nurses.
We need to be able to recognize and manage them.
Absolutely. And each of those conditions has its own unique pathophysiology assessment findings and treatment approaches.
Right.
But the good news is the concepts that we've discussed today will help you understand those conditions on a much deeper level.
This is all so fascinating, but I have to admit my brain is getting a little full.
I know, it's a lot of information.
Can we take a break and come back to explore those specific respiratory conditions?
Of course. Let's give those brains a rest, and we'll be back soon to dive into the nitty-gritty of managing common respiratory problems.
All right, so we're back.
We are back,
Ready to tackle those common respiratory conditions.
ready to put all this knowledge into practice.
Yeah, that you're actually going to see, like out there in the real world.
Out in the clinical setting.
My brain is recharged,
Good.
ready to absorb more knowledge.
Excellent. It's like prepping for a nursing skills marathon.
It is.
You got to fuel up to master those techniques.
Yes, so let's start with pneumonia.
Pneumonia, okay.
I remember from my textbooks, it's an infection of the lungs.
Right.
But what does that actually mean for the patient? Like, how does it affect their breathing?
Think back to our discussion about the alveoli and gas exchange.
Okay.
With pneumonia, those tiny air sacs get filled with fluid or pus,
Oh.
which basically creates a major roadblock for oxygen trying to get into the bloodstream.
So it's like those alveoli are drowning.
They're drowning in inflammatory gunk.
Yeah, that can't be good.
No, not good at all.
What kind of signs and symptoms would we see in a patient with pneumonia?
You'll often see, those classic signs of infection like fever, chills, fatigue.
Okay.
But the respiratory symptoms are key. Cough, shortness of breath, and sometimes chest pain, especially when they take a deep breath.
Okay.
And remember, those symptoms can vary depending on the severity of the infection and the patient's overall health.
Right. So an older adult might present differently
Exactly.
than a younger, healthier person.
Absolutely.
Got it. Now, what about asthma?
Asthma, another common one.
Yeah, another one we hear about all the time.
All the time.
Yeah.
So asthma is a chronic inflammatory condition that affects the airways, those bronchioles we talked about earlier.
Right.
Remember how they branch out like a delicate tree, getting
Yeah.
smaller and smaller? Well, in asthma, those airways become hyper-responsive to triggers,
Okay.
like allergens, irritants, or even exercise.
And when they get triggered, those airways basically freak out.
They freak out.
Yeah.
The muscles surrounding the bronchioles constrict, causing bronchospasm.
Oh.
And the lining of the airways swells up, producing excess mucus.
Okay.
All of that narrows the airways, making it difficult to breathe.
So it's like someone's trying to breathe through a straw that's been pinched almost shut.
Yeah, that's a good way to visualize it.
What are the key signs and symptoms that we would see in a patient who's having an asthma attack?
Wheezing is the classic hallmark,
Okay.
but you'll also see shortness of breath, coughing, and chest tightness.
Okay.
And it's important to note that the severity of an asthma attack can range from mild to life-threatening.
Right.
So we need to be prepared to act quickly in those emergency situations.
Okay, that makes sense. Now, COPD is another chronic lung disease
COPD, yeah,
that I know we're going to see a lot of as nurses.
we see it a lot.
What makes COPD different from asthma?
So COPD is actually an umbrella term that includes chronic bronchitis and emphysema,
Oh, okay.
and it's usually caused by long-term exposure to irritants like cigarette smoke,
Okay.
and it leads to irreversible damage to the lungs.
So it's not just about inflammation like in asthma.
Yeah.
There's like actual structural damage going on.
There's structural damage.
Yep.
So in chronic bronchitis, the airways are constantly inflamed and produce excess mucus, making it hard to breathe.
Okay.
And in emphysema, the walls of the alveoli are destroyed,
Oh.
reducing the surface area for gas exchange.
And less surface area means less oxygen getting into the bloodstream.
Exactly.
So COPD patients are basically fighting a losing battle.
They experience shortness of breath, especially with exertion, chronic cough, wheezing, fatigue. And as the disease progresses, their quality of life can be severely impacted.
It sounds pretty grim. Is there anything we could do as nurses to help these patients?
Absolutely. While there's no cure for COPD, we can help manage their symptoms and slow down the progression of the disease.
Okay.
Things like smoking cessation, pulmonary rehabilitation, and medications to open up the airways and reduce inflammation can make a big difference.
So it's all about supporting them in the long haul
Yes.
and maximizing their quality of life.
Exactly.
Now, the last condition on my list is pulmonary embolism,
Pulmonary embolism.
which sounds particularly scary.
It can.
What exactly is happening in a PE and what makes it so dangerous?
So remember our discussion about VQ mismatch?
Yes.
Pulmonary embolism is a classic example of a high VQ where there's good ventilation but poor perfusion because a blood clot is blocking blood flow to part of the lung.
So air's getting to the alveoli, but the blood can't get there to pick up the oxygen because
Exactly.
of the clot.
Because of the clot, and depending on the size and location of the clot, this can be a life-threatening situation.
Right.
The blocked blood flow not only affects oxygenation, but also puts a strain on the heart, which has to work harder to pump blood through the remaining unobstructed vessels.
What kind of signs and symptoms would tip us off that a patient might be experiencing a PE?
Sudden onset of shortness of breath is a big red flag,
Right.
along with chest pain that often gets worse with deep breathing.
Okay.
You might also see a rapid heart rate, low blood pressure, and even signs of shock in severe cases.
So it's a clinical emergency
It is.
that requires quick thinking and action. What would our role as nurses be in managing a suspected PE?
First and foremost, recognize the signs and symptoms and call for help immediately.
Okay.
Early diagnosis and treatment are crucial for improving outcomes.
Right.
We'd also need to anticipate orders for diagnostic tests like a CT scan and medications such as anticoagulants to break up the clot.
Wow. We've covered a lot of ground today.
We have.
Pneumonia, asthma, COPD, pulmonary embolism, these are all such serious conditions
Yeah.
that we as nurses really need to have a solid grasp on.
A solid grasp.
It's amazing how much we've learned from just one document.
I know, it's amazing how much information is packed into those clinical resources.
It is.
But remember, this is just the beginning of your journey into the fascinating world of respiratory care.
It is.
As you progress in your nursing education and career, you'll continue to build upon this knowledge and develop your skills in assessing and managing patients with respiratory problems.
This deep dive has been so helpful in connecting those textbook concepts to real-life clinical scenarios.
I'm glad to hear that.
I feel much more confident now in my ability to approach respiratory assessment and care.
That's fantastic to hear. Remember, nursing is all about lifelong learning.
Right.
Keep asking questions, stay curious, and never stop seeking knowledge.
Well, I'm definitely feeling inspired to keep diving deeper into the respiratory system.
Awesome.
Thanks for guiding us through this complex but crucial topic.
It's been my pleasure. And to all you future nurses out there, keep up the amazing work you're going to make incredible healthcare professionals.
That's all for this deep dive. We'll be back soon with another deep dive into a new topic. Until then, keep those brains engaged and those stethoscopes handy.